We'll move up to the next speaker because we are really short of time. And sur le scanner en très haute résolution, que devons-nous espérer par le professeur Prokop. Thank you very much.
Thank you very much, Philippe. In this coming talk, I will talk about the current efforts to increase spatial resolution in CT. Here are my disclosures. Now, if you look at the technique of high-resolution CT, then the resolution depends on the number of rays that pass through the patient, and that is again dependent on the number of detector elements and the number of projections. And it also depends on the thickness of these rays, which again depends on the size of the detector elements, but also on the focal spot. And finally, it depends on image reconstruction, whether you use a specific filter kernel or iterative reconstruction. Now, if you measure resolution, we've seen a few of these modulation transfer functions already. They are a function that show how specific spatial frequencies, which conceive a certain resolution, are transferred by the imaging system. In this situation, for example, of a specific spatial frequency, 1.5 line per millimeter, about 50% is actually ending up in the image, and the rest is reduced in terms of contrast. If you go to 20% of the MTF, the line per centimeter that are seen on these curves get higher. And usually what we see in the companies when they give the spatial resolution of a scanner, they are not using 50%, they are using usually 4 or 0%, which of course gives them very high numbers, which are not really realistic in clinical practice, because these high numbers only play a role with ultra-high resolution in high contrast structures like the petrous bone. Now here you can see a standard resolution scanner, and you can see if you transfer that into line pairs, it's substantially lower. This is high resolution, and this is a standard scanner, where at 0 MTF with the ultra-high resolution mode or filter kernel, you end up with 15 line pairs, but in a more realistic situation, soft tissue would be about 6 line pairs per centimeter. Now, how can we improve our spatial resolution? There is one version to create more projections, which means that we can read out the detector faster, which means you need faster detector materials, or you have to rotate slower so that you do get more projections at the same readout speed per rotation. Another thing is a LED grid that shields half of the detector element, which therefore reduces the effective detector element size by half, but it also means that only half of the dose that is given to the patient is ultimately used for image reconstruction. Another way would be to use smaller detector elements, in other words, smaller crystals, and ideally thinner septa. And finally, we've heard photon counting, which in theory gives you a really point response, but in practice, that's not really a point response, but there's a little bit of crosstalk. So these images that you see down here are not realistic. They look like the one we have here. Let's see what I can see. No, I can't show it. So it's actually the same cylindrical shape, but a little narrower. We've seen all that. I'm going to jump. Now, if you look at ultra-high resolution conventional CT, filter kernel is the most important factor. We all know that. It determines the in-plane spatial resolution, but also it determines the noise. So you see that if you have higher noise, you get also higher spatial resolution. In other words, higher spatial resolution comes with the penalty of higher noise. Now, what we have to realize that the pixel size in our normal CT depends on the field of view. We have a 512 matrix, which means that for a field of view of 25 centimeters, we have a pixel size of 0.5 millimeter. For the abdomen with a field of view of 40 centimeter, this would be 0.8 millimeter. So the field of view is actually determining the pixel size. But the pixel size is not the spatial resolution. The spatial resolution is determined by your filter kernel that you're using, and it's usually substantially larger. in the brain and in the abdomen, we have pixel size or resolutions in the range of 0.8 to 1.2 millimeters for the kernels we're usually using. That's something that we don't realize, but that's about the spatial resolution we get. In the extremities, on the other hand, we can get very high spatial resolutions if you use an ultra-high resolution filter. Now we have seen model-based iterative reconstruction, and this is a slide from Ellen Bloom. We do see that the spatial resolution with these model-based reconstructions becomes dependent on the dose. You see for filtered back projection and the second generation iterative reconstruction, the spatial resolution is independent of the dose, but if you go to model-based iterative reconstruction, you can see that if you give higher dose, actually the resolution goes up. But what's not shown here, if you go to substantially lower dose, the resolution also will be reduced. It takes actually maximum advantage of the scanner capabilities, so it gives you the optimal resolution that you can achieve with a certain dose. Now we can see that for many manufacturers, here's Toshiba, or how it's now called Canon. If you go to iterative reconstruction, the struts of these stents are much more clearly visualized, and you also see much better the fact that there is actually intimal hypoplasia. And similar, if you go from a second generation iterative reconstruction to IMR, the third generation by Philips, we see very similar results. Here an example from GE where you can see nicely the trabeculation in this arthrography. Now, what we do see as we go from filtered back projection to iterative reconstruction, again, a second generation iterative reconstruction, it will take away a lot of the artifact, especially in the shoulder region when we talk about high resolution CT. But if you look very closely, it will also introduce some minor blur in areas where we do have enough dose. Now, if you go to these model-based iterative reconstructions, we do see that there is less noise, less artifact, but also increased sharpness. So it's, again, very similar to what we've seen, and it actually increases that over filtered back projection. Here, again, in an enlarged fashion, you see much more detail as you go to these model-based iterative reconstructions. However, if you reduce the dose, what you will see is that in this situation, 0.2 millisieverts, so an ultra-low dose CT, the second generation iterative reconstruction gives you a slightly sharper image than the model-based one, because the model-based one tries to really reduce the noise significantly, but it has to get it doesn't have the information to do so, so it slightly blurs the image. Now, ultra-high resolution CT is something that we're already available, but outside most radiology department, it's cone beam CT, usually used for dental exams or for maxillofacial surgery. The resolution can be excellent. Inner ear image is quite amazing with 150 micrometer resolution, but there's a massive difference between the various scanners out on the market, especially when it comes to the artifacts you can see. And they're basically cone beam artifacts that can be quite disturbing in these systems. Now, one of the problems with resolution is that we have this relationship between the resolution and the dose. The theoretic the relationship between those two is 1 over dose to the power of 4, which basically means that in order to decrease the spatial resolution in all 3 dimensions by a factor of 2, it basically means that we would have to increase the radiation by a factor of 16. And that's massive, which basically means if we use normal filtered back projection, this is definitely not an option. So here we see an example of these grid-based images, very good resolution, for example, of the stapes here, but at higher image dose. Here, a situation with an ultra-high resolution detector that actually gives you voxels in the range of 0.25 cubic millimeters and a very high spatial resolution where you even see the stapes muscle. One of the problems that we see is as we go to these higher resolution is that the noise will go up. So containment of noise will become the most important factor when we go to ultra-high resolution imaging. We're basically operating in a detector signal starved environment. Now, when we want to push the envelope towards ultra-high resolution imaging, we have a couple of things that we can do to get our images better. One is to reduce the dose. The second one is to reduce the noise perception by improving contrast, and then finally to focus on suitable regions. We can reduce the noise by using better detector systems with higher dose efficiency, and those are those with less electronic noise. And here, photon counting is ideal because it has no electronic noise, but most of the new detectors actually have substantially lower electronic noise than earlier systems. And finally, use iterative reconstruction to do noise reduction. Then improvement of contrast we can do by low kV scanning or monoenergetic images with low kV. We can pre-filter our X-ray beam in order to remove those beams that are not really contributing to the dose in the image, and we can optimize our contrast injection in order to optimize the contrast in the patient. Finally, focusing on suitable regions would be lungs, bone, or CTA, where we do have intrinsic high contrast, or in areas where there's low absorption, like the lungs, head and neck, or the extremities. We've seen the photon counting detectors. It can be energy selective, depends on many energy bins you want to create. But if you want to push the resolution, we run into a big problem of the massive amount of data that you get. You do not only get, let's say, if you push the resolution by a factor 2, twice the amount of data per projection, but you actually will get up to 8 times the amount of data if you want to use 4 energy bins. And that is, at the moment, one big limitation for photon counting detectors. But in specific situations where you do low rotation speeds, you can get excellent image qualities. Currently, however, these photon counting detectors give very similar spatial resolutions or modulation transfer functions as energy integrating detectors, so conventional detectors. The MTF is actually slightly worse than for our conventional energy integrating detectors. Now, I'm going to quickly talk about ultra-high resolution detectors. They are actually built on a superfine detector grid with super thin septae so that there's very little dead space. They have an effective element size of 0.25 millimeter by 0.25 millimeter. Their new detector materials and more rapid readout to make it possible to get more projections. And then the whole imaging chain has to be optimized to get rid of image noise. 2 pre-filtering, better iterative reconstruction, numeric scatter suppression, and binning of detectors for normal resolution modes if you are working in really huge patients where high resolution is not possible. This is the MTF that you get. It is substantially higher than what we can see in conventional scanners and in photon counting scanners. Again, the image that we saw. Here's an example where we are looking at tiny electrodes, which are below the resolution of any normal CT. But with this scanner, you can nicely see the electrodes in the cochlea, and we have even succeeded showing whether it's in the scala tympani or in the scala vestibuli. Here's an example for the extremities, very high resolution, good display of the trabeculae, and all types of pathology. We can also use that in the lung, where we here see a patient with emphysema and pulmonary fibrosis, especially when it comes to the definition of small honeycombing. This is a very suitable way of doing it. Again, here coronal reformation with excellent resolution in all planes. This patient had a small bronchogenic carcinoma as well. We can use that also for types of visualization, like here visualization of the vessels and the bronchi, where again the resolution is outstanding. Bronchogenic cancer, just the same. With the newest way of iterative reconstruction, we're now able to reduce the dose substantially compared to earlier experimental versions of the scanner. And ultimately, what we'd like to do is go into ultra-high resolution quantitative imaging. And here's an example from not a high-resolution scanner, but a regular scanner, where there's a quantification of the vessel diameter, which is actually quite a good predictor of the presence of functional abnormalities in emphysema. And by using various of these characteristics, the prediction of whether a patient has COPD or not is actually possible with an area under the curve and an RSC curve of about 0.92 with the current technologies. Now here an example in the abdomen. We see excellent trabecularization in the bones, but also very high resolution of all tiny structures. For example, the nerve roots, the vertebral arteries. What also is interesting is that in these high-resolution scanners, if we do subtraction imaging, pre-contrast, post-contrast imaging, where we do get iodine maps, which are actually superior in signal-to-noise ratio to any dual energy technique, the registration becomes really superior. These are images without additional noise suppression, which is usually used in dual energy. Here in these subtraction imaging using the high-resolution scanner, that has been not applied, and still the image quality is substantial. You see a small lesion in the pancreas. Now the challenges here are that we do get this resolution only if we go from 512 matrix to 1K matrices. If you have large fields of view, like in the abdomen, the pixel size becomes limiting because the spatial resolution is in the range of about 0.4 to 0.3 millimeters. C resolution is actually higher than the XI resolution, so the in-plane resolution. Which gives us the funny situation that with these high-resolution detector, we have anisotropic imaging and the resolution being in Z direction bigger than in the XI direction. We can actually go to even higher matrix sizes to 2048, and that actually gives us near isotropic imaging, and pixel size becomes no longer limiting, as you can see. The problem there is, however, that the relative data size kind of explodes. So for clinical purposes, we're usually ending up around 1K matrices, or in future maybe 768, which is a really good balance between image quality and the amount of data we are generating. Here's another challenge that we're getting, and that's motion. Here's a standard CT compared to an ultra-high resolution CT, and you can see that the spatial resolution is superior, but also in the red circle, what we do see is that there's pulsation artifacts, and these pulsation artifacts become much more clear because if you have a resolution of basically the size of a grain of salt, any pulsation can give us problems. Noise is another issue. Here's an 0.2 millimeter ultra-high resolution image of the pancreas. That's a patient in which the question was, is that an IPNM, an intraductal papillary mucinous tumor? We see the image quality is okay, but it's quite noisy. The dose is less than 10 milligray, and the effective dose was 4 millisievert. Now, as we go to thicker sections, then the image quality becomes much more acceptable. And if you take second generation or third generation iterative reconstruction, image quality becomes okay, even at the very thin image sections. And then now very new reconstructions using neural network reconstructions actually give us clear images and very acceptable image noise. And it turns out that this patient actually has a carcinoma. On the subtraction image, you see the lack of enhancement. And here's a coronal image where you can see the carcinoma and an IPNN in the same patient. So to summarize, spatial resolution depends very much on how it's measured. So if you have only a number, but not the way it has been measured at which part of the MTF, you cannot really compare it. It requires many projections and small detector elements to get the best results. It can be optimized with model-based iterative reconstructions, even on conventional scanners. But the higher resolution usually requires higher dose if you want to take advantage of the maximum you can get. We have, as techniques, cone beam CT, which are usually not available for radiologists. We have the opportunity to use detector grids. They're usually only used in areas like the inner ear or extremities. We can optimize iterative reconstruction, find detector elements, or photon counting in the future. In order to get optimal results, we should focus on high contrast applications or situations where detector dose can be sufficient. It can also be suited in high absorption regions, especially if radiation dose is not an issue. And we've heard about the AHARA principle, as high as reasonably achievable, and that actually should go to the benefit of CT. And that is one of our most important indications now in our clinical practice. It's the staging before major tumor surgery. There actually radiation dose is really not important because the surgery is the important risk factor. So really optimizing the diagnosis beforehand is the most important factor. But other areas where it definitely makes sense to use that is high resolution CT of the lungs or the inner ear. and CTA of the coronaries, brain, mesentery, and runoff, where we have an intrinsic high contrast. With that, I thank you for your attention.